Patient safety is something that is of fundamental importance for all of us who are involved in healthcare. And today it's assuming great importance, relevance, and the fact that we meet every year for a conference of this nature speaks of its importance. In 2008, at the hospital, we introduced a clinical risk management program. And just for simple definition, we know this is a particular approach that looks at areas that can cause harm or produce adverse events. And then when you look at this, you identify the areas that cause these problems for patients, which make it unsafe for patients, analyze these areas, find solutions, and then audit whether you've actually attained what you wish to do. To do this, you have to form a committee, and this committee involved an obstetrician, neonatologist, a gynecologist, an anesthetist, and somebody representing the administration. Of course, the committee has absolutely no authority to dispense with employees, but just looks at data and gives us information that helps us improve on what we can. What is important when you're looking at this kind of data to improve and to find solutions is to go down to the root cause, particularly in a critical incident. Just looking at data, our two speakers have emphasized that enough, the need to dig deep and find solutions. The emphasis obviously is not focusing on the person but on the system. How did we fail? Was it a very tired physician who worked long hours? Was it poor training? A machine that didn't work? Now, my topic today is a clinical incident. So let's just look at that. Anything which gives rise to or has the potential to lead to unintended, unwanted, unexpected harm, loss, or damage to an individual would be regarded as an incident. And of course, you could categorize this as a near miss or an adverse event. Near miss in the last several years, particularly in the last decade, has assumed great importance in the maternity mortality sector, because we now find that it's easier to look at data of near miss to help eventually reduce maternal morbidity and mortality. Just a few examples of clinical incidents, and we're very familiar with this. So let's get on to certain examples. It's important that in that culture of the hospital, you actually encourage reporting, don't shoot the messenger, and make sure that the organization sees a change when things are reported. For this, we introduced a simple incident form, and the form then is reviewed by the committee at the end of the month. And we actually, for about a whole year, had a list of possible incidents that could be looked at so people could get used to the culture of reporting, and then introduce these boxes at all nursing stations. And what gave me a lot of hope was the fact that in the last 2 years, we've actually had nurses put in incident reports or expressed concern about patient safety. The incident evaluation form is quite comprehensive and helps to divide the incidents into various categories. And let me just run through 4 very simple examples. There was a mother who was admitted at the age of 26 weeks gestation, pre-viable with ruptured membranes, and she was leaking. And we failed to pick up the possibility of severe infection. And if it had not been caught in time, she could have gone on to having septicemia, and we could have had a maternal death. This was reported by a nurse, and the committee looked into it, and we found that yes, you have a high turnover of nurses, doctors, and we needed a lot of in-house training And one of the simple things that we introduced was an early warning chart, which we grabbed from the NHS, adapted it to our situation. And I must say, today this has proven to be of great help across the two hospitals, particularly in the ICUs and the HDUs.